dear doctors, this is going to be one of the important topics in our day-to-day practice. Infections in diabetes. Yes. So the effect of the infection on the diabetes impairs the glycemic control by increasing insulin resistance due to the release of the cytokines and the counter-regulatory hormones. So whenever there is an infection, especially in the diabetic individuals, so that impairs the glycemic control by increasing insulin resistance. Infection is frequently a precipitating factor for the ketoacidosis. So as I told you earlier, the DKA, so commonest cause for the DKA is an infection. It could be a urinary tract infection or respiratory tract infection or skin and soft tissue infections, etc. So it's a vicious cycle. So the more the infections, more the chances of uncontrolled diabetes, and more the uncontrolled diabetes, that is hyperglycemia, so the more the chances of getting the infections. So in the presence of the diabetes, any infection has to be controlled very effectively. So very possible antibiotics or antifungal or antiviral. So you have to control all these infections, the diabetes. Otherwise, most of these diabetes people will be land up in the sepsis and multi-organ failure and the death. So the predisposing factors for infections in the diabetes. So the diabetes is considered an immunocompromised state of immune system functions. So you have the cellular innate immunity, humoral innate immunity, cellular adaptive immunity, and humoral adaptive immunity. The cells involved here are the neutrophils, monocytes, macrophages, T lymphocytes, B lymphocytes, plasma cells. And there are the different defects noted in the diabetes. The reduced neutrophil chemotaxis, adhesion, and phagocytic function. So more and more infections. Reduced production of the reactive oxygen species, leading to the impaired killing of the pathogens. Again, more and more infection. Impaired macrophage or monocyte chemotaxis and the phagocytic function. So once there is impaired function, obviously more and more infections. So these are all the different pathophysiological mechanisms of getting more and more infections, like elevated resting values of the pro-inflammatory cytokines, like your high sensitive CRP or tumor necrosis factor, interleukins, etc. Again, more infection. So what are the predisposing factors for infections in the diabetes? The secondary factors, the peripheral vascular disease. So once the peripheral vascular disease means there is an obstruction to the distal flow. So that area will become more and more ischemic, and more ischemic zone will lead for the more infections. That's what happens in your diabetic foot ulcers. Peripheral neuropathy. So because of the loss of the sensations, so even a trivial injury will give you a route for the entry of the bacteria into the body and leading to the diabetic foot ulcers and infections. And CKD population will be having the anemia, and again the anemia is a big predisposing factor for the infections, and CKD population will have the less immunity and they are more prone for the infections. And the dialysis, so definitely a route of the infection is very easy in the dialysis individuals because of these catheter induced or hospitalized or nosocomial, etc. And urinary catheters and intravascular lines, so they leads to a lot of the cellulitis, thrombophlebitis, and then the entry of the organisms and then causes the sepsis. So these are the very good number of the diabetic individuals. So they land up with the sepsis with the presence of the peripheral vascular disease and the peripheral neuropathies or the CKD. These people are on the dialysis and the catheters and intravascular lines, etc. Predisposing factors for infections in the diabetes. Agent-specific factors, especially the Candida albicans and the rhizopus. See, high glucose levels. They stimulate the Candida to produce certain complement-like proteins. We promote the adhesion of the Candida to the vagina and the buccal mucosa. So that is a reason. Sometimes, vaginal candidates could be the initial diagnostic point to diagnose the diabetes. In the same way, oral candidiasis. So in our practice, when the fellow is presenting the oral candidiasis, maybe 2 or 3 reasons. One is uncontrolled diabetes. The second one is HIV positivity. That is the AIDS. And sometimes the people on chronic steroid therapy or chronic alcoholism, etc. So there is the oral candidiasis. So sometimes the oral candidiasis may extend up to the esophageal candidiasis or the gastric or the candidial candidiasis. They are very, very common. Foot infections and diabetes is a very big topic. In the next class, I will take up the exclusive talk on the diabetic foot. So here, for the discussion sake, it is a common initiating event that results in the limb loss. So whenever you see an amputated fellow on the road, In India, there are only two reasons. One is a traumatic amputation, otherwise a diabetic amputation. But 60% of the lower extremity amputations are subject to the diabetes are due to the infected foot ulcers. Infections are often polymicrobial. So gram-positive, gram-negative and anaerobic infection. So that is the reason in all the foot infections, we use the three drugs. So one is for the simple rural population or the not affordable, we use the ampicillin or gentamicin and metronidazole. So those people who can afford, we use the ceftriaxone, amikacin and metronidazole. In sometimes, we can use the tazobactam or meropenem and then the amikacin and the metronidazole. So we have to cover all the three organisms. So gram-positive, gram-negative and anaerobics. So don't be happy with only with the ampicillin or only with the ceftriaxone. So you need to add the gram-negative and also anaerobic drugs in all the foot infections. Diabetic foot infection is a potential emergency. So can become a serious in a matter of the hours. Within few hours, the blister that will become a ulcer, and then finally there will be the big cellulitis, and then the acute peripheral vascular diseases, and then maybe the loss of the limb also. So all diabetic foot ulcers is an emergency. You should think that. More details later. As I told you, so in the next class we will take up the exclusive class on the diabetic foot. Common infections: urinary tract infections, cystitis, pyelonephritis, renal or perinephric abscess. So urinary tract infections are very common in diabetic individuals. There may be the urethritis, then there may be the cystitis, there may be the ascending UTIs, then the pyelonephritis, and finally the abscess formations, and finally we have to sacrifice the kidney on that particular side also. So sometimes so right nephrectomy or the left nephrectomy for the simple reason of uncontrolled urinary tract infections, ascending infections leading to the pyelonephritis. Respiratory tract infections, they are very, very common in our society. Staph aureus or gram-negative pneumonias or pneumococcal pneumonias, etc. So finally, sometimes they may cause the lung abscesses, and tuberculosis and diabetes is a big problem. Skin and soft tissue infections, surgical wound infections, foot infections. So these are also very common. Your simple paniculitis, some cellulitis, some abscess formations, these are very common. Abdominal infections are very common in our population, like salmonella enteritis or shigella or cholera or simple gastroenteritis with mixed organisms. These are very common. Eye infections, stye, hordeolum externum or hordeolum internum causing the chalazion, and water infections, periodontitis. So that is also very common in our population. So the water infections, eye infections, abdominal infections, skin and soft tissue, respiratory tract, urinary tract infections. These are all the common infections we often see in diabetic individuals. So this is the one case, male 25-year-old, a building construction worker, undergoing treatment for pulmonary tuberculosis with no family history of the diabetes. BMI is very normal, 22. Blood pressure is also normal, 120/80. Does this patient require screening for the diabetes? So because a good combination between the diabetes and pulmonary tuberculosis, all the pulmonary tuberculosis should be screened for the diabetes. All the diabetics with uncontrolled cough or localized, night sweats or evening rise of the temperature. So definitely have to rule out the pulmonary tuberculosis. Up to 14% of the patients with the TB have the diabetes. Diabetic patients have a relative risk of TB 3:1. Studies show that 5 to 30% of the patients with the diabetes have tuberculosis. What are the peculiarities of TB in diabetic patients? More likely to have the pulmonary rather than the extrapulmonary tuberculosis. See, all the tuberculosis are common in diabetic individuals, whether it is pulmonary tuberculosis or extrapulmonary tuberculosis. In the extrapulmonary tuberculosis, we have the cervical lymphadenopathy, mediastinal lymphadenopathy, retroperitoneal lymphadenopathy. Sometimes the people will have the pericardial effusions, tuberculous pericardial effusions, tuberculous meningitis, tuberculous spondylitis, pot spine, tuberculous osteomyelitis, or psoriasis major muscle infections, or tuberculous epididymoarthritis, tuberculous salpingitis. So you name anything. So all the organs in the body will be affected with the tuberculosis. That is extrapulmonary tuberculosis. Even the pulmonary tuberculosis is also very common. So in the pulmonary tuberculosis non-diabetics, So you can see the upper lobe involvement. Whereas in the diabetics, all the lobes are equal involved. Not only the upper lobe tuberculosis, even the mid lobe tuberculosis, or even the lower lobe tuberculosis is also very common in a diabetic individuals. So relatively positive the physical signs leading to the delayed diagnosis, extensive caseation and cavitations, more likely to be sputum positives. So sputum positive means open cases. So they are at high risk of uh, spreading the disease to the public. So all the diabetic individuals, pulmonary tuberculosis, AFP positive, so you have to treat with the ATT very effectively and also with the insulin. Because once you start the insulin in a diabetic and pulmonary tuberculosis, so this AFP conversion is also will be very fast. So they will become AFP negative within very fast, so that you can save the community, not spreading the pulmonary tuberculosis to our community population. Minimal pleural involvement, delayed sputum clearance, and treatment failure, relapse, reinfections are very, very common in diabetic individuals. So treatment failure, they don't take the drugs for the 6 months. So that is going to be a treatment failure and the resistance. Relapses and the reinfections. So last 10 years back, he had a pulmonary tuberculosis and treated with all the 4 drugs effectively. And this time also again, he got the relapse. Sometimes maybe the relapse, sometimes with the new infections. That is the reinfection. Insulin is the drug of choice for controlling the blood glucose in individuals with the tuberculosis. Rapid improvement in the glycemic control helps in correcting the cachexia associated with the tuberculosis, helps in the healing process. I told you, insulin should be given for all the 6 months of the ATT, at least in the first intensive phase. So if the patient wants the OHA, don't give any OHAs with diabetes and TB, at least in the intensive phase. So along with your 4 drugs, INH, rifampicin, ethambutol, pyrazimide, you should also start using insulin. So OADs can interact with the anti-tuberculosis drugs, especially rifampicin, and should be used only in the mild hyperglycemia. So otherwise, what will happen if you use the OHs and the rifampicin? So the rifampicin drug dosage will not be maintained in the blood, and the people will develop the rifampicin resistance. INH can worsen the peripheral neuropathy. Tight glycemic control is essential for success of the anti-TB treatment, and tight glycemic control is possible only with the insulin therapy. Diabetes and HIV. Diabetes is not considered a risk factor for the HIV. So all the diabetes won't get the HIV. But people living with HIV and AIDS are more likely to have a type 2 diabetes because of the 2 reasons. One, the virus directly attacks the pancreas to cause the pancreatic insulin deficiency, or the drugs what you are prescribing for the HIV therapy, they may cause insulin resistance to cause more and more diabetes. So drugs used in the heart therapy, that is highly effective antiretroviral therapy, can predispose to the development of the diabetes. See, definitely heart therapy is a big game changer in the management of the HIV population. I have a lot of the population with HIV positivity. Once you start on the ART, they are almost behaves like a normal individuals. So now HIV is not a killer. It's like a chronic disease, like your diabetes and hypertension. Both protease inhibitors and nucleoside reverse transcriptase inhibitors, NRTS, have been implicated. Both these affect the both insulin secretion as well as the insulin resistance. NRTS produce diabetes by affecting the insulin sensitivity as well as the lipodystrophy and mitochondrial dysfunction. Strongest association is the stavudine. Other drugs used to treat the comorbidities like pentamidine can also predispose to the diabetes. Incidence of iatrogenic diabetes in HIV patients has been assessed as high as 5.72 per 1,000 person years follow-up. Insulin again is the treatment of the choice in heart-induced diabetes. So in the tuberculosis, at least in the first intensive phase, you have to use the insulin. In the same way, when the HIV population, when the CD4 count is very, very low, so you have to use the insulin at least to keep the viral load to the negligible level and the CD4 count above 500 or above 1000. Now the diabetes and COVID-19. Diabetes does not increase the risk of contracting the COVID-19, but individuals with the COVID-19 have an increased risk of adverse outcomes of the COVID, such as severe disease, ICU admissions, need for assisted ventilation, and finally the death. So you all agree with me that a lot of our diabetic individuals, when they contacted with the COVID-19, so early death because of the early DKA, because of the more sepsis, because of the more multi-organ failure. So a lot of our diabetic individuals, when they contact with the COVID-19, so they got very severe disease. The poor outcomes may be partly due to the comorbidities such as advanced age, obesity, hypertension, CVD, CKD, and also other infections are more common in the COVID-19 patients with diabetes than without diabetes. Poor glycemic control at admission and during the hospital stay, as well as admission HbA1c are independent predictors of the outcome. So when the fellow admitted with the COVID-19 with HbA1c 10 or 11, it is very difficult to survive him. On the other hand, when the fellow's HbA1c 6.5 or the 7, when they got admitted with the COVID-19, the survival rates are very, very good. So the survival of the patient of the diabetes plus COVID-19 depends on your HbA1c. That means your control of the hyperglycemia. Target blood glucose maintained between 140 to 180. Oral antibiotic agents can be used if not contraindicated, especially the gliptins. So sitagliptin is used very extensively in those periods. In mild COVID, and if hyperglycemia is not severe. When the blood sugars are very high, what is your drug of choice? Obviously, insulin. Only in the mild diabetic individuals, if you want to skip the insulin, then the gliptins are the favorable choices. In all other situations, insulin should be initiated. So guidance on the use of the OHS. Prescribed oral OHS, no contraindication, mild COVID and mild hyperglycemia. Guidance on the use of the insulin therapy. Prescribe the insulin. There are the contraindications of the OHS. Moderate to the severe COVID. Moderate to severe COVID means between the 180 to 250 milligrams of the blood glucose. Then you have to use the insulin therapy. So the new onset diabetes, the COVID-19 mechanisms, COVID-19 infection, effect on the beta cell, direct cytopathic effect, directly they damages the beta cells. They cause acute pancreatitis, that means both exocrine and endocrine dysfunction, immune mediated destruction. So they all cause the beta cell destruction. So beta cell destruction means hyperglycemia. On the other hand, effects of the systemic COVID-19 infection, stress response, cytokine storm, steroid therapy, so they are all cause insulin sensitivity reduction. So more and more insulin resistance. So one hand resistance, on the other hand deficiency, so cause new onset hyperglycemia of the diabetes, or if the patient is already a diabetic, worsening of the glycemic control. So step 1, do a random capillary blood glucose at the time of the admission. Step 2, perform a pre-meal and the post-meal blood glucose with the first major meal in the hospital. Step 3, send the blood for the fasting and the HbA1c next morning if the lab facilities are available, and then act accordingly. If the blood sugars are very, very high, use insulin. When the blood sugars are less than the 140 or less than the 150, 160, use the gliptins. And you have to maintain between 140 to 180. 140 to 180 is your target. So blood glucose monitoring strategy for individuals with no evidence of stress hyperglycemia or undiagnosed diabetes at that initial screen. No hyperglycemia at admission. Severity of the illness increases. Patient is initiated on the steroids. Then the high risk individuals, cardiovascular diseases, obesity, elderly. So monitor the blood glucose twice daily. Management of the steroid induced hyperglycemia. So this is also very common in the COVID era. So they were normotensives at the time of the admission, but because of the steroid therapy used during the COVID times, so they became the hypertensives, hyperglycemic at a later time. So the no previous diabetes, use the insulin very low, 0.2 units. Already are 1 or 2 OHS, use 0.4. More than the 2 OHS, 0.6. Definitely diabetes not under control, you have to maximize the insulin. You need not remember all these things. But one thing is very clear, steroid induced hyperglycemia will be there and treat accordingly. When their blood sugars are very low, you can treat with the OHA. When they're very high, you have to start the insulin at a different dosages. So the rare infections predominantly associated with the diabetes mellitus. See, these are the rare, but they are very particular in diabetes mellitus, like malignant arteritis externa, rhinocerebral mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis, emphysematous cystitis, necrotizing fasciitis, Fournier's gangrene. So whenever you see such type of infections, you have to order the blood sugars, and you see that the patient must be a diabetic, because these infections are predominantly associated with the diabetes mellitus. Here one study, 65-year-old taking treatment for type 2 diabetes for the last 16 years. One day he comes to you with complaints of severe left ear pain and ear discharge. 7th cranial nerve palsy on the left side. So left ear pain, left ear discharge, and the left 7th cranial nerve palsy. Fasting blood sugar 235, postprandial 357, WBC 28,000. First culture from the ear discharge is positive for Pseudomonas. So what is our diagnosis? So it is a malignant arteritis externa. How will you manage the patient? So surgical debridement is very much needed, not the medical management. So surgical debridement. What is the prognosis? Bad, grave prognosis, guarded prognosis. So don't say that the patient is 100% recovered in this patient. No, it is not possible. So malignant arteritis externa is a very bad disease. It is a pseudomonal infection of the external acoustic meatus and the skull also. So getting the meningitis, getting the brain abscesses also very common, left untreated. Found in elderly patients with the diabetes. Presents with severe pain, discharge, and features of the facial palsy. Treatment is by aggressive debridement and anti-pseudomonal antibiotics like your linezolid, etc. High mortality even if treated. So this is another study case. A 45-year-old male, type 2 diabetes for the last 5 years. Currently on a combination of glimepiride 1 mg plus metformin 500 mg twice a day. Recently he contracted COVID-19 and was hospitalized, at which time he was administered IV dexamethasone for 10 days. So very common. A 45-year-old, 5 years history of the diabetes, good control with just the glimepiride 1 mg plus 500 milligrams of the metformin BD. But unfortunately he got the COVID-19 and he was given dexamethasone steroid for 10 days. 1 week after the discharge, he presented to the doctor with a headache, fever, and anorexia. On examination, there was swelling over the eyes and proptosis, more prominent on the left side. He was unable to open the left eye since morning on the day of the visit to the doctor. On examination of the nasal cavity, a black discharge was found with a scar over the left inferior nasal turbinate. Random blood sugar 450, A1C 11.4. I have seen nearly 8 to 9 cases are like that. So what is your working diagnosis? So rhinocerebral mucormycosis. What is the prognosis? Eye loss. Infection of the nasal mucosa, nasal cavity, orbit by fungi, rhizophus, and the mucor. Found in the debilitated patients, especially those with the DKA. Increased incidence found among individuals with COVID-19, particularly treated with the steroids. Fever, pain, extraocular muscle palsy, proptosis, and chemosis. Black eschar seen over the nasal turbinates. Venous sinus thrombosis, brain abscess are the common complications. Treatment, surgery, amphotericin B, posaconazole, high mortality even if the treat. Some people know they lost the eye also. Okay. Now the one eye people, whenever you see in our right now, no. So the post-COVID, post-steroid therapy, post-mucormycosis. Now this is another case. Necrotizing fasciitis. Very, very common in diabetic individuals. Common sites are abdomen, perineum, and extremities. Very extensive infections. If you touches the muscle, no, that will ooze out, coming out. So presents with the pain and other local signs of the inflammation. Initially spares skin and the muscle. Infection of the soft tissue caused by the streptococci, staphylo, and anaerobes. There are 3 types. polymicrobial, group E, and Clostridium. Diagnosis by the culture from the necrotic center of the lesion. Treatment, debridement and surgery and broad spectrum antibiotics. A prolonged hospital stay is needed here. So the foreigner's gangrene, again very common. It is the perineum, scrotum and the penis. E. coli, bacteroids, streptococcus, staphylococcus, pseudomonas and the proteus. Scrotal pain and swelling with a systemic toxicity. So the failures are very toxic. The foreigner's gangrene are also the necrotizing phase. Your blood WBC will be 25,000, 30,000, etc. Sloughing of the scrotal skin, shameful exposure of the testis and the spermatic cord. So it's a surgical emergency. Unroofing of the lesion, broad spectrum antibiotics. Architectomy is very common, may be needed early, and also the high mortality. So one case here, a female, 46-year-old, type 2 diabetes on OHS, fever for the last 3 days, vomitings, abdominal pain, and dysuria. Patient is very toxic, febrile, dehydrated, severe tenderness over the left renal angle. So what is your working diagnosis? So yes, urine examination, plenty of the pus cells, pus cache, acetone is negative luckily, fasting 268, urea 52, creatinine 1.4. Her total WBC nearly 40,000. So what is your working diagnosis? So emphysematous pyelonephritis. What investigation will confirm the diagnosis? So your ultrasound abdomen and also your X-ray abdomen. So gas producing organisms, etc. What is the line of the management? So admissions, IV fluids, IV insulin, IV antibiotics. Okay, investigation, see whether the kidney is working well or not. So when the dye is not going there, so definitely have to sacrifice the kidney nephrectomy also. Otherwise, we are DJ shunting, etc. So emphysematous pyelonephritis, necrotizing infection of the renal parenchyma and the surrounding tissue. Almost exclusively found in patients with the diabetes. Females more common. E. coli and Klebsiella, mostly gram-negative organisms. Gas is formed by the fermentation of the glucose. Radiological demonstration of the gas can be seen on the X-rays. Management, broad spectrum, percutaneous drainage of the pus, nephrectomy. Effects of the infection on the diabetes. Glycemic control tends to be deteriorated during the infection. Patients on insulin may need to increase their dosages. Patients on OADs may need to switch to the insulin. So once the patient is on the basal insulin, you have to uptitrate the doses because of the intensification of the insulin. Once the patient is on the OHS, stop OHS, start insulins. So severe hyperglycemias are inability to retain the oral fluids warrant the admission. Severe infection may precipitate the DKA, not only in the type 1 diabetes, but also in the type 2 diabetes. Any infection in the body, so there may be a potential risk of getting the diabetic ketoacidosis. Vaccinations, so you have to give the influenza vaccination, pneumococcal vaccination. Okay, so these are all the vaccinations. And nowadays, no zoster vaccination. So these are all hepatitis B vaccination. So these are all possible vaccinations. So thank you very much for your sparing time.